Let's get into patient assessment. What we have to start with is primary patient assessment. Primary patient assessment is essentially about deciding whether your patient needs emergent care, whether your patient is going to die in the next 5 minutes or 10 minutes, and if there's anything you can do about it. This is the most important step that we can take right now to ensure that we have the best outcome for our patient. So how does primary patient assessment start? The first thing we have to do is look at the scene. Now, there are several components that come into play when we're talking about the scene. One of the things we look at is the scene safe? When we say is the scene safe, what we're really talking about is the scene safe for a couple of different people. First off, us, the rescuer. Is the scene safe for us to enter? If it's not, we don't go in. By going into a dangerous scene, all that has happened is we've put ourselves in a position where we can become a patient. Now, not only do we have 2 patients, but we don't have any rescuers at this point. You have to ensure that the scene is safe for you. If the scene is not safe, do not go in. The second part of safety is ensuring that the scene is safe for the bystanders, the rest of the group, everyone else you're hiking with, or anyone else that you come upon. Make sure that nobody else gets injured. Finally, we want to then make sure that the scene is safe for the patient. Ensure that they are not in a dangerous situation, that they're not in immediate danger of getting hit by a rock fall, getting fallen on by a tree, or in a situation where the scene could potentially become unsafe. If we follow these 3 simple steps, we're going to make sure that everybody stays safe. After scene safety, comes clues. Now, clues is a kind of broad term, but I like to use clues because it helps us think about all the things we're looking for. When I say clues, what I want you to think about, is there anything that can tell me what might have gone wrong? What may have happened to this patient? Now, I can get clues from a lot of different areas. I can get clues from bystanders. I can get clues from the patient. I can get clues from the scene or the situation itself. However, don't mistake clues to mean that there's a certain problem. And let me give you an example. If there was a person who went to the roof of this building right now and jumped off the roof of this building and landed on their head outside on the pavement, right? The question I would ask you is, what do we know about that patient? Now, there's a key word there, and that is know. What do we know about that patient? And what you have to remember is the only thing you know about that patient is they leapt off the roof and they landed on their head. Don't make assumptions about problems because we haven't assessed the patient yet. They may be injured, they may have a problem, but I don't know that. Why that's important is because if I assume that because this patient leapt off the roof and landed on their head, that they have a head injury, I'm going to go into this situation expecting to find a head injury. When I don't find a head injury, I'm going to be completely baffled. Also, if we go into a situation with tunnel vision, looking for one thing, it's going to exclude everything else that I might want to find. So when we say clues, what we're simply looking for is there any indication, is there any information that I can get that might help advance what I'm trying to find? I'll take that in, and then I'll use it as I go forward. Finally, when it comes to scene is number of patients. How many patients do you have? That's really important. It may seem that there's only one patient, but I want to confirm that. I want to make sure that there's only one patient, not one patient and someone else who fell off the trail and is hidden in the bushes, or one patient who made it out of the tent and another patient who's passed out inside. Just confirm that there's only one, or that there are 2 or 3 or 4. This is your first step in your primary assessment, checking out the scene. After you've evaluated the scene to make sure that it's safe, to get some clues, and to check for the number of patients, we want to now approach our patient and check to see if they're responsive. Is my patient responsive? Now, sometimes when I ask this of students, I say, what does it mean to be responsive? And the answer comes back, well, they respond. Now, we typically don't like to define words using the word itself, but yeah, that's what we're looking at. I want to know that if I come up to my patient, do they interact with me somehow? Now, this could be a wide range of interactions. It can be the person who talks with me. It can be a person who's screaming. It could be a person who's moaning, or it can be a person who's just making incomprehensible sounds on the ground. Those all represent a responsive patient. Yes, they present a wide variety of problems or degree of difficulty that you're going to have to manage, but they all mean they're responsive. And I am simply looking for, is my patient responsive? Does my patient respond to me? This is really important because I want a responsive patient. Even though sometimes responsive patients can be more difficult to manage than unresponsive patients because they want to talk to you, a responsive patient means that this patient has all the vital functions going on. All right. With an unresponsive patient, I'm going to have to check those things. I'm going to have to make sure that this unresponsive patient is actually alive. So we split these patients into two categories. Simply say, yes, they're responsive. No, they're not responsive. That's it. Yes or no. If my patient is responsive, that's nice, and I'll tell you how we manage that in a second. And this is going to be 99% of all the patients you're ever going to find. All right? But we do have the occasion where you might find an unresponsive patient. You have someone who does not respond to some stimuli as you approach. With this unresponsive patient, we simply want to make sure that they are alive. How do we do that? Well, we're going to check circulation, airway, and breathing. Circulation, airway, breathing. CAB. How do I check those things? Circulation. What I'm looking for is, does this person have a pulse? Is this person's heart beating? On an unresponsive patient, what we're going to do is we're going to check for a pulse at the carotid artery. Now, the carotid artery, they're located on either side of the neck. All right. Right here is your trachea. And down the side of your neck, you can feel there's a muscle here. This muscle is called the sternocleidomastoid muscle. You don't have to know that term, just know that there's a muscle there. Here's your trachea, here's the muscle. Right in between this little valley. In this valley is where your carotid artery runs. I'll give you another little trick, and you can practice this. If you put your hand just like this and turn it, your fingers will land just about where your carotid artery is, and you'll be able to find that pulse. You want to check for a pulse. Now, why do we check it on a carotid artery on an unresponsive patient? We do that because this is the last pulse to disappear in a patient. This pulse will be there all the way to the end. So if this one's not there, I know nothing is there. So check for that pulse. If your patient has a pulse, you can move forward to your next step, which is going to be airway. If your patient doesn't have a pulse, we stop. What we're going to do here is CPR. Now, CPR is a separate class. We can teach you that as well, and it's a really important skill to learn. But right now, we're going to keep going with our patient assessment. So if your patient has a pulse, you keep moving on to airway. If your patient does not have a pulse, you stop everything else, and you move right into CPR. So now we're going to move to airway. When it comes to airway, we have to think about what the problem is with an airway. What are we dealing with? Well, what we're worried about is actually a blockage of the airway. Now, before you start thinking about choking, I don't want you to do that. We're not talking about choking here. We're talking about an airway obstruction that's going to cause this patient to not be able to have any air move past them. Well, choking can do that. If I have an unresponsive patient, we are not going to worry about choking. What you're going to worry about is the tongue. If a patient's airway is going to be blocked or obstructed, it's going to be due to the fact that their tongue has fallen back into the airway. When a person passes out, becomes unresponsive, what happens is all their muscles relax. Your tongue's a muscle. When you're falling down, that tongue, that muscle, is going to fall back in the airway, and it will obstruct the airway. Let me show you. Here's a human head, right here. Here's the head. If you look, here's the nasal passages. This is the oral passages right here. This goes down, you have a trachea. In the back, you have an esophagus. If this patient passes out, you can see here's the tongue right here. And you can see how it's occluding or blocking the airway passages. Now, I need to get that tongue out of the airway. There are a lot of different ways I can do that. There's only one thing you need to do. All you're going to do is tilt the head. That's all you have to do. By tilting this patient's head backwards, what you've done is open this airway, and you've opened it by pulling the tongue up out of the airway. Simply tilt the head back. That's it. Now, to maintain the patient in this position, you can put something under their neck to hold their head like this if you want, but you just have to keep that airway open. All you have to do is do the head tilt. Put their head back. That's it. Once their head is back, you know their airway is open. Again, do not worry about choking. You're not blocking their airway because of choking. Their airway will be blocked because of the tongue. Tilt their head back, you'll have an open airway. C, A. So now we're on to B, and that's breathing. Now I have to make sure that this patient is breathing. How do I ensure that this patient's breathing? There's lots of different ways that we can do this. You may have heard things like looking for chest rise, watching for the stomach to expand in and out. And all of those things are good. What you need to understand about breathing is it's actually really difficult to see if someone's breathing normally, especially if they're wearing a lot of clothes. It can be very, very hard. So what you want to do is use all the tools together to ensure that this patient is breathing. Yes, we're going to look for chest rise. Get your head down. Look along the plane of their chest to see if their chest is moving in and out. Put your hand on their chest. Put your hand on their diaphragm to see if you feel that movement. Get your head right down next to their ear and their mouth. Do you feel air movement? You can put your hand here. You can use a mirror. You can use glass to see if they get fogging. Any of those things, you just want to see, is this patient breathing? If they're breathing, wonderful. We're going to move on. But just like circulation, if this patient is not breathing, they're not moving air in and out, you're stopping. And you're going to go right into CPR. Again, CPR is a really important skill that you need to learn. We're not going to talk about it in this class, but it is a skill that you should learn. So if they are breathing, you move forward. If they're not breathing, you stop and you move into CPR. So how does this translate to the responsive patient, right? Because with the unresponsive patient, I check all those vital systems: circulation, airway, breathing. Well, in a responsive patient, the nice thing is I can check those simply by asking a question. You walk up to the scene, you check the scene for safety, for clues, for numbers of patients. You check if they're responsive. And if they're responsive, they give you some response, then you know they have a pulse, they have an airway, and they are breathing. How do you know that? Well, because I walk up and I say, "Hey, sir, ma'am, what happened? What's wrong? What's going on?" And the patient may be sitting there holding their arm, screaming, yelling, crying, right? Gasping, breathing really hard, whatever it happens to be. And they say, "Oh, it hurts. Oh, I tripped. I fell. Oh, I cut myself. I'm bleeding." All of those things. Well, if they're doing that, if my patient says, "My arm hurts," I know they have a pulse. If they say, "My arm hurts," I know their airway's open. And if they say, "My arm hurts," I know they're breathing. Because if a patient can interact with you, if they are responsive in some fashion, I know that they have a pulse, they have an airway, and they're breathing. Doesn't necessarily mean they're good. We're going to get there in secondary assessment. But at least right now, I know they're alive. And that's what primary assessment is meant to do. So I've made it through CAB. I have to check one more thing that falls into the category of life threats. And that's what CAB are. They are your life threats. They are the things that will kill you in the next few minutes. So the last thing is what we're going to call a rapid trauma scan. A rapid trauma scan is designed to find any other life threats that may be existing on this patient that we haven't been able to find with CAB. Specifically, we're looking for major bleeding. Now, we'll get into bleeding a little later on when we talk about soft tissue injuries and wounds, but right now I just want you to think life-threatening bleeding. What does it look like? It looks exactly like you would expect it to look like. You'll know life-threatening bleeding when you see it. You will look at it and you will say, that's life-threatening bleeding. What you're trying to find is if this patient is bleeding out. How do you do that? Well, in the middle of summer, it's very obvious. They're wearing shorts and a t-shirt. You'll be able to see life-threatening bleeding. In the middle of winter, there may be a lot more clothes on. You may or may not be able to see it readily. So what do you need to do? Well, you're going to have to evaluate that patient. The rapid trauma scan is called that because we use our hands and we rapidly assess the whole patient. We're simply looking for those life threats, for specifically that life-threatening bleeding. I may come across other injuries. You may find a broken arm. You may find a broken leg, right? You may find pain on the chest or bruising on the abdomen. Those are what we're going to call secondary injuries. We're looking for primary injuries, injuries that will kill a patient now. If I find life-threatening bleeding in that assessment, I'm going to stop and deal with it, just like I managed circulation, airway, and breathing. Now, we'll talk about how you manage life-threatening bleeding a little later on. I just want you to be aware of that we have to assess for it. So now I've done my rapid trauma scan. I've assessed for that bleeding, and I've either taken care of it or they didn't have any and I've moved on to the last step in your primary assessment. And that's what we call the environment. And what this means is we have to manage for the environment. We have to manage the patient and the environmental conditions that we're encountering. Is the patient in a safe place? Do I need to move them? Is it really hot outside? I need to put them in a cooler spot. Is it really cold outside? I need to get them in a warmer spot. Is it an area that I'm able to treat my patient? Take care of all those things. Making a patient comfortable is not just about making them comfortable. Adding a mat to the ground and putting your patient on it, putting a hat on their head, a coat on their back, putting them in a sleeping bag, those all make a patient comfortable and the patient feels nice. But a comfortable patient who feels nice has physiologic changes. It slows their heart rate down, brings their blood pressure down, brings their breathing down, tamps down that adrenaline response, all of which help me get a better sense of what's actually going on with my patient. So to recap, when we come in with a primary assessment, our job, our goal, is to ensure that this patient is not going to die on me in the next 5 minutes. I want you to think of this like an emergency room. What is the job of an emergency room? Their job is to have a patient come in and quickly assess them to make sure they're not going to die in the next 5 minutes. Now, any of you who've ever been to an emergency room for something, maybe it was a broken arm or a broken leg, have experienced this. You came in, it was the worst day ever. Your arm, it's sticking out of your skin. The EMTs wrapped it all up. You're holding it. It's really painful. There's a flurry of activity around you in the room. And then somebody says to you, all right, someone will be in to see you soon. And then what happens? You wait, and you wait, and you wait. Why? It's not because they're not taking care of you. It's because they recognize that you're not going to die right now. So they're going to go out, they're going to take care of the people who are dying. They're going to do a thorough assessment on you and come back and take care of you. That's what our primary assessment is. We're going to come in and make sure you're not going to die. Take care of the problems that could kill you. And if there aren't any, take a big deep breath, get through to environment, and then we'll move on to secondary assessment. Primary assessment. Start with scene. Is it safe? Find any clues. How many patients do we have? Is my patient responsive? No. Do they have a pulse? No pulse? Do CPR. They have a pulse? Airway. Make sure the airway's open. Breathing. Are they breathing? No. Do CPR. Yes. We can move forward. If my patient is responsive, ask them a question. What happened? What hurts? What's wrong? They interact with you, you know they have a pulse, you know they have an airway, you know they're breathing. Do a rapid scan to make sure there's no other life threats. Make sure they're in a safe place. Make sure you're in a safe place. And we'll be able to move forward and manage our patient.